save time, and be awesome.
All right, this lecture is going to provide an overview of the autonomic nervous system. In the next 4 lectures, we're going to be dealing with drugs that act as agonists and antagonists of the sympathetic nervous system. And these autonomic drugs and these autonomic receptors are very basic foundational stuff. You really need to understand this very well for pharmacology and for your board exams. Even if this is a review for you, it's really important stuff to understand. In this lecture, we're going to cover the difference between the autonomic nervous system and the somatic nervous system, both in terms of structure and function. We're going to talk about the function of the sympathetic and the parasympathetic systems, and we're going to talk about the different types of receptors that are involved. So first we need to talk about the central nervous system versus the peripheral nervous system. Now this is purely structural. The central nervous system is the brain and the spinal cord. The peripheral nervous system is basically everything else. The peripheral nervous system is divided into the efferent division and the afferent division. Now the efferent division is taking signals away from the central nervous system, and the afferent division brings signals to the central nervous system. Now you hear different pronunciations for these terms. Sometimes people will say efferent and afferent. Those aren't technically correct, but they're a little easier to understand when they're spoken quickly, so it's acceptable to talk that way. It's easy to remember the difference between the two. Efferent starts with E, like emit, so the brain emits efferent signals. Afferent starts with A, like accept, and the brain accepts afferent signals. Now, we talk about signals rather than nerves because a nerve has a bundle of lots of different fibers, and those individual neurons are one-way transmitters. They're either sending afferent signals or efferent signals, but an individual nerve bundle is going to have signals going in both directions. So the efferent division of the nervous system is divided into the somatic system and the autonomic system. The somatic system is primarily talking about control of voluntary muscle, skeletal muscle. The autonomic nervous system, on the other hand, is regulating and modulating a lot of different bodily functions and integrating bodily functions. And this is done without any conscious or voluntary control. We're talking about control of smooth muscle in blood vessels, in the gastrointestinal tract, in the biliary tract. We're talking about control of cardiac muscle, control of exocrine glands like the sweat glands and the salivary glands, and control of the endocrine glands such as the adrenal gland. The autonomic nervous system then is divided into 3 components: the sympathetic nervous system, the parasympathetic nervous system, and the enteric nervous system. And we'll come back to each of those, but first let's talk about the general anatomy. In general, the autonomic nervous system is efferent. It's made up of 2-step systems. There are 2 neurons involved for each signal. The first neuron has a cell body in the central nervous system, either in the brainstem or in the spinal cord, and then it makes a synapse in a ganglion. And a ganglion is a bundle of nerve cell bodies where a lot of synapses are made. These are housed outside the central nervous system. It's kind of like a relay station. And then the second cell of the signal is originating in the ganglion. The cell body is located in the ganglion, and it sends its axon out to the organ that's going to be affected, whether it's the heart or the gastrointestinal tract or the smooth muscle or whatever. And the cells are named in relationship to the ganglion. So that first cell, where the cell body is housed in the spinal cord, is going to be the preganglionic neuron. And then the cell that goes out from the ganglion, where the cell body is housed in the ganglion, is the postganglionic neuron. And this is very important terminology because we're going to see different types of neurotransmitters used, preganglionic versus postganglionic, and they're used in different sites. Now, there are also some afferent components to the autonomic nervous system. It's not purely efferent. There are afferent fibers that are involved in reflex regulation of this system. For example, you have baroreceptors or pressure receptors that are located in the carotid sinus, and these are going to sense the blood pressure, fluctuations in the blood pressure up and down, and they're going to relay this information to the central nervous system, which can then alter the autonomic output in order to raise the blood pressure or lower the blood pressure accordingly. This is all unconscious. This is all involuntary. This is not somatic mediated. This is going on constantly and you're never really aware of it. If you stand up too quickly after you've been sitting or lying down for a long period of time, your blood pressure may drop dramatically and you'll feel it. But generally, when your blood pressure fluctuates a few points here and there, you're not really aware of it at all. So we mentioned 3 divisions of the autonomic nervous system: sympathetic, parasympathetic, and enteric. We're going to talk briefly about the anatomy of each one, and then we'll talk about function and the transmitters and the receptors involved shortly. So first, let's talk about the anatomy of the sympathetic neurons. The preganglionic neurons arise in the spinal cord, as we said, the spinal cord in the thoracic division of the spinal cord and the lumbar division of the spinal cord. And these axons exit the spinal cord, and they're very short axons, and they synapse in the sympathetic chain of ganglia, which is just parallel to the spinal cord, just outside the spinal cord. And there's one on each side. And so they have a synapse at the ganglia, and then there's a postganglionic neuron that arises from the ganglia, obviously, and then they project long axons from the sympathetic chain to whatever the effector organs are. So the preganglionic axon is very short, the postganglionic axon is very long in the sympathetic nervous system. Now there's one notable exception to this, and that's in the adrenal medulla. Here, the preganglionic fibers don't go to the sympathetic chain of ganglia, they go directly to the adrenal glands. The adrenal medulla is basically a modified form of a sympathetic ganglion. The adrenal medulla is developed from the embryonic neural crest cells. They don't have axons, they don't have dendrites, but otherwise they're basically like modified neurons. And when they receive that preganglionic stimulation, they're going to release their neurotransmitters, which is primarily epinephrine. They're not going to release them out of a nerve terminal and project that to an effector organ. They're going to release that epinephrine into the circulation, where it's going to go throughout the body and have the effects throughout the body. Now let's talk about the anatomy of the parasympathetic system. The preganglionic parasympathetic neurons arise in the cranial nerves numbers 3, 7, 9, and 10. So they're arising in the midbrain and they're carried out of the brain through the cranial nerves. The cranial nerve 10, the vagus nerve, is very important in the parasympathetic system. It innervates the heart, the bronchi, the esophagus, the stomach, the intestines, most of the abdominal vasculature, the liver, and the pancreas. So everything from basically the clavicles to the pelvis is going to be innervated parasympathetically by the vagus nerve. Preganglionic parasympathetic neurons also arise from the sacral division of the spinal cord, and these are the pelvic splanchnic nerves. And they innervate the distal colon and the kidneys and the bladder, and also the gonads and the genitalia. The preganglionic axons exit the spinal cord or exit the midbrain, and they're carried out not to a chain of ganglia like the sympathetic system was, but they have long preganglionic axons that go out to the visceral organs. And they synapse in ganglia, but those ganglia are either distributed in the tissues or in ganglia that are just outside the tissues. And so they synapse in those ganglia, and then they project short postganglionic axons to their effector organs. You'll notice I was fairly specific about which organs are innervated by the parasympathetic system. And this is to point out that the parasympathetic system is much more selective than the sympathetic system. When you get a sympathetic discharge, the preganglionic axons are all crossing over and switching around in that sympathetic chain of ganglia. And so when you get a sympathetic stimulation, it stimulates the whole sympathetic system all at once. With a parasympathetic system, it's much more one-to-one. One preganglionic neuron is innervating one postganglionic neuron, and it's affecting one effector organ or target organ. So it's much more selective. You can get much more discrete stimulation of the parasympathetic system that way. Let's talk briefly about the anatomy of the enteric nervous system. There's also this huge network of nerve fibers and ganglia that innervate the GI tract and the biliary tract and the pancreas. And this is the enteric nervous system. This all functions completely independently from the central nervous system, although it is sometimes modulated by the autonomic nervous system. It's so independent it's sometimes referred to as the brain of the gut. And the enteric nervous system is going to regulate motility in the GI tract. It's going to regulate microcirculation to the GI tract. It's going to regulate some of the exocrine function, especially the pancreas, and also endocrine function. So that's the anatomy of the different portions of the autonomic nervous system, and we're really done talking about the enteric nervous system. From now on, we're going to be talking about sympathetic and parasympathetic systems. So first, let's talk about the function of the sympathetic nervous system. Now, you've probably heard of this. We talk about the sympathetic nervous system as causing a fight or flight response. We're dealing with stress, and it can be lots of different types of stress. It can be emotional stress or fear or anger. It can be stress from a trauma or injury. It can be stress from hypothermia or hypoglycemia. It could be stress from physical exertion or exercise. So lots of different types of stress. It's like when you're driving down the street and you see a cop with a radar gun pointed at you, and you get that instant thud in your heart, and all of a sudden you're a little keyed up. That's that surge of adrenaline. You feel that. You know exactly what that feels like. That's your body's preparation to fight the stress or to flee from the stress. And that's all triggered by systemic epinephrine and norepinephrine. But you get the same transmitters affecting the sympathetic nervous system and affecting the individual organs. Remember, this is an all or nothing system. It functions as a complete unit. The nice thing about it is you can pretty much figure out the response of each end organ to sympathetic stimulation by thinking about what does the body need to respond to stress? What does it need to fight or flee? So let's talk about specific effects of sympathetic stimulation. And you'll see this in Lippincott's on page 37, figure 3.3. So again, how does the body respond to stress? What does the body need to fight or to flee? In the heart, sympathetic stimulation causes increased heart rate and increased contractility because you need more blood flow to get more oxygen to the tissue so they can fight. In the trachea and the bronchioles, you have dilation so that you can get more oxygen in and deliver more oxygen to the tissues to fight. In blood vessels and skeletal muscle blood vessels, you're going to dilate those blood vessels with sympathetic stimulation so you can deliver more blood and more oxygen to those muscles. Other blood vessels, such as blood vessels to the skin and the GI tract, mucous membranes, these blood vessels are going to contract when you get sympathetic stimulation. So you're shunting blood away from those non-essential organs and shunting it to the muscles so you can fight or flee. In the gastrointestinal tract, sympathetic stimulation is going to cause decreased motility and decreased muscle tone. And it's also going to cause contraction of sphincters, so the anal sphincter, the pyloric sphincter. The thinking is you don't need to digest food. You certainly don't need to be trying to defecate when you're fighting some kind of stressor. In the urinary system, sympathetic stimulation is going to relax the detrusor muscle. That's the muscle that causes the bladder to contract and then so you urinate. And it also causes contraction of the urinary sphincter. So again, you don't need to be urinating when you're fighting a stressful situation. In women, sympathetic stimulation causes relaxation of the uterus. I can't really explain why that is other than maybe you can think about it as when you're fighting stress, you don't need to be going into labor. In men, sympathetic stimulation triggers ejaculation. Now, obviously, you have to have an erection first. You have to have some physical arousal first. And that is all parasympathetically mediated. We're going to talk about that in a moment. But thankfully, even though that we think of the sympathetic system as a system-wide all-or-nothing response, obviously when you get a big sympathetic discharge, you don't automatically ejaculate. You have to have the erection first. In the kidneys, sympathetic stimulation causes secretion of renin, which is a hormone that leads to vasoconstriction. Renin secretion can also be triggered by drops in blood pressure. When the blood pressure gets lower, the kidneys sense that and they secrete renin independent of the sympathetic stimulation. And that renin then leads to vasoconstriction and raises blood pressure. A couple of other sympathetic effects. In the eyes, sympathetic stimulation is going to cause dilation of the pupil or mydriasis. I think about this as if you're going to be fighting something, you need to see it really well. So you need to open up the pupils and get as much light in as possible. So mydriasis from sympathetic stimulation. In the salivary glands, sympathetic stimulation will cause thick, viscous secretion, thick, viscous saliva. This will be a lot easier to remember in a moment when we talk about parasympathetics. And then finally, in the sweat glands or the eccrine glands, you get increased sweating from sympathetic stimulation. Now, remember when we talked about seeing that cop with the radar gun? You get that kick in your heart, you feel your palms get sweaty. This is a sympathetic response. But it's not mediated by epinephrine and norepinephrine. This is one of the rare places in the body where you have a different transmitter used in sympathetic stimulation. We'll talk about that in a moment. Just file that away for the moment.
Okay, now let's pause for a moment and review the material that was just covered. Before we do that, if you haven't already done so, this might be a good time for you to read your pharmacology text that corresponds to the material that was just discussed. Then together, we're going to go through the quick review in your study guide. All right, let's go through the answers to quick review number one. Number one, what is the pathway that the sympathetic nervous system uses to stimulate the heart? And how does it compare to the pathway that the parasympathetic nervous system uses to slow the heart? So two different distinct pathways. The sympathetic nervous system doesn't have a specific nerve bundle that goes to the heart. Instead, what it does is stimulates the adrenal medulla, and the stimulation of the adrenal medulla causes a release of epinephrine to go through your circulation, and that is what increases your heart rate and contractility. On the other hand, your parasympathetic nervous system uses the vagus nerve. Number two, an ICU patient with septic shock is being given epinephrine and IV fluids to maintain an adequate blood pressure at a mean arterial pressure of greater than or equal to 65 millimeters of mercury. Little clinical pearl here. For ICU patients in shock, the mean arterial pressure needs to be above 65 millimeters of mercury, mean arterial pressure. So based on what you know about the effects of sympathetic stimulation, what are some of the potential consequences of this epinephrine dosing? So some of the things you might see in patients in the ICU that have high-dose epinephrine on board to maintain adequate blood pressure because of septic shock is you can have poor perfusion to the skin, especially the fingers and toes, the most distant reaches of the skin. And sometimes when you see these patients, their fingers and toes will be cold, even sometimes blue, and it can get to such severity that you can even have necrosis from poor perfusion to those extremities. Additionally, another thing you might see with high-dose epinephrine in the ICU patients is a poor perfusion to your visceral organs. So this includes the kidneys and GI tract. So too much epinephrine can really shut down your kidneys. It's going to cause an ileus of your GI tract. So you're going to be essentially sacrificing those organs to maintain perfusion to your heart and brain, which are more important. But over time, your kidneys can only be shut down for so long. Number three, true or false, epinephrine can be inhaled as a component of asthma treatment. This is most definitely true. Now, traditionally, we don't use epinephrine to treat asthma. We use something more like albuterol. But the reason why we do that is because epinephrine has a lot of side effects, like tachycardia. However, this inhaled epinephrine is actually sold over the counter. It's Primatene Mist. So it's something that definitely can be used. Number four, which cranial nerves are components of the parasympathetic nervous system, and what does each do? So there's four main cranial nerves that were components of the parasympathetic nervous system that were discussed earlier in lecture. The first one was cranial nerve 3, which is your oculomotor nerve. Now the parasympathetic component of the oculomotor nerve causes meiosis, and which is pupillary constriction. So you cause constriction because of parasympathetic. Now a little pearl about cranial nerve 3. It's a very interesting cranial nerve. Think of cranial nerve 3 as two nerve bundles. The inner nerve bundle is the one that causes your oculomotor muscles to be stimulated to move your eye. The outer nerve bundle of cranial nerve 3 is your parasympathetic nerve bundle that causes this meiosis or pupillary constriction of the eye. And this is clinically important because if you have a phenomenon such as a brainstem herniation that compresses cranial nerve 3, the first thing that's going to go is the parasympathetic component. So you might have a patient who's able to move their eye around just fine because that inner bundle is protected, but that outer bundle may be compressed, and that's going to cause what's called a blown pupil because you lose that normal meiosis of the eye. But moving on to the next cranial nerve that's parasympathetic is cranial nerve 7, which is your facial nerve. So some of the things that this nerve is going to do is cause facial sweating and also salivation. Cranial nerve 9 is your glossopharyngeal nerve. So cranial nerve 9 monitors your carotid baroreceptors, also monitors your chemoreceptors of your carotid body and carotid sinus. Cranial nerve 10 is the next one. This is your vagus nerve, of course. Normally when you think of parasympathetic activity to your body, you think about the vagus nerve. It is responsible for lots of different things. It monitors your aortic arch chemoreceptors and baroreceptors, regulates blood pressure that way. Stimulates the GI tract, so this is your rest and digest, is mediated by the vagus nerve. Also, a slowing of the heart rate and decreasing of the heart contractility is mediated by the vagus nerve at the SA node, the sinoatrial node. One other important brainstem structure I want to talk about is your nucleus solitarius. And I'm mentioning this because your nucleus solitarius of your brainstem consists of your cranial nerve nuclei for cranial nerve 7, cranial nerve 9, and cranial nerve 10. And so this is a very important brainstem nucleus that has visceral sensory information. So sensory information regarding how distended your gut is with gas or with food. Your baroreceptor information, also taste information, comes through this nucleus solitarius, which is important for parasympathetic efferents later on. Number 5. Which autonomic nervous system is most responsible for regulating blood vessels and blood pressure? This is a sympathetic nervous system by way of 2 main receptors, by way of your alpha-1 receptor that causes vasoconstriction, and also by way of your beta-2 receptor that causes vasodilation. Now, when you think about autonomic pharmacology, and this is a theme that you're going to hear us reiterate over and over again, the autonomic nervous system in your body is rest or digest. You're either stimulating parasympathetic or you're stimulating your sympathetic nervous system. And your sympathetic nervous system has multiple different receptors. But when you talk about pharmacologic innervation of your autonomics, you're either going to stimulate your sympathetic or you're going to inhibit your sympathetic. And then you're either going to stimulate your parasympathetic or inhibit your parasympathetic. So the complexity of autonomics is doubled when you're talking about autonomic pharmacology versus just your intrinsic autonomic system. Because with pharmacology, you can stimulate the autonomics or you can inhibit the autonomics. So it's something to be aware of. Let's go to the next question. What are the main receptors of the autonomic nervous system, or what are some of the primary functions of each? So this is a bit of a preview of something we're going to discuss later, but I think it's very important and worth mentioning, so you have this preview. So you have your alpha-1 receptor, which is one of your adrenergic receptors, one of your sympathetic receptors, and this is responsible for vasoconstriction, causes contraction of smooth muscles. Your alpha-2 receptor is a presynaptic autoreceptor that decreases sympathetic outflow. Your beta-1 receptor is also another adrenergic receptor. It increases heart rate and contractility, also increases renin secretion. This results in increased angiotensin and also increased aldosterone, and increasing aldosterone by way of a renin pathway is going to result in increased sodium and water retention. So it's going to not only increase heart rate and contractility, it's going to increase water retention by way of increasing renin. Beta-2 is responsible for bronchodilation and vasodilation. So those are 4 important adrenergic receptors to solidify in your mind. Alpha-1 vasoconstriction, alpha-2 is a presynaptic autoreceptor that decreases sympathetic outflow. Beta-1, think about the heart, think about increasing renin, and then beta-2, think about bronchodilation and vasodilation. So your 2 main parasympathetic receptors, your main parasympathetic neurotransmitter is acetylcholine, but you have your muscarinic acetylcholine receptors, and these mediate all of your parasympathetic activities, including bradycardia, slowing down of the heart rate by way of what nerve? Your vagus nerve. And also by stimulating muscarinic acetylcholine receptors, you're going to stimulate leakiness in your body. And we'll talk about this again in a little bit, but you're going to have more lacrimation, more salivation, more sweating, more urination. You're going to increase gut motility, which is more likely to cause diarrhea. So the 2 main things to think about for parasympathetic by way of your muscarinic acetylcholine receptors are bradycardia and leakiness. Now, another acetylcholine receptor is the nicotinic acetylcholine receptor, and this has a very unique function, which we're going to discuss again later. This is a preview, but your nicotinic receptors are on all of your skeletal muscles. So skeletal muscles use nicotinic receptors. Your nicotinic receptors are also on all of your autonomic ganglion. Your presynaptic ganglion use your nicotinic acetylcholine receptors. And so to stimulate the sympathetic nervous system pathway and also to stimulate the parasympathetic nervous system pathway, you have to go through nicotinic acetylcholine receptors at the ganglion first. And if this is confusing to you, don't worry. We're going to talk about it again later. That's why this is a preview here. So that's it for this quick review.
What are the two main types of cholinergic receptors? What year are you? You are, without a doubt, the worst excuse for a medical student I have seen in a long, long time. I don't know what you're going to do when you flunk out of here because you're not even fit to teach high school biology. The main types of cholinergic receptors are muscarinic and nicotinic. Now, I suggest you go do some reading and come back when you know something. Go, morons.
So next let's talk about the function of the parasympathetic nervous system. If the sympathetic nervous system is fight or flight, then parasympathetic is going to cause you to rest and digest. Unlike the sympathetic nervous system, which is not really necessary for day-to-day function, the parasympathetic nervous system modulates things that are very important and very necessary for day-to-day function. Things like moving food through the digestive tract, things like elimination of waste. Parasympathetic effects are usually the opposite of sympathetic effects. They're usually balancing the sympathetic effects. For instance, they're going to balance the control of blood pressure and that sort of thing. We already mentioned that the parasympathetic system is more selective and more specific in the way it works. You can have a parasympathetic neuron fire and just innervate one specific organ as needed. When it discharges, it doesn't fire as a complete system as the sympathetic system does. So let's talk about specific effects of the parasympathetic stimulation. So again, let's start with the heart. Parasympathetic stimulation of the heart is going to reduce heart rate and reduce contractility. And think about it, at rest, you don't need so much blood, you don't need so much oxygen going out to the tissue, so you can slow the heart down some. In the gastrointestinal tract, it's going to cause an increase in motility, again, to move food through so you can digest it. In the trachea and the bronchioles, it's going to do the opposite of what the sympathetic system did, so the parasympathetic system is going to cause constriction of the trachea and the bronchioles. And what I think about is you don't need so much oxygen, so you can contract the trachea and the bronchioles down a little bit. In the trachea and the bronchioles, it's also going to increase secretions. So those respiratory airway secretions are going to increase with parasympathetic stimulation. Now this is a common feature of parasympathetic stimulation, increased secretions. One way to think about it is that everything in your body that can become leaky becomes leaky when you stimulate it parasympathetically. So we talked about GI motility. If you stimulate the gut with the parasympathetics, you're going to have leaky GI system. You may get diarrhea. You're going to have more defecation. In the lacrimal glands or the tear glands, you're going to have increased tearing, increased tear production with parasympathetic stimulation. In the salivary glands, you're going to have copious watery secretions with parasympathetic stimulation. And I said, remember, that's just the opposite of what the sympathetic system does. In the urinary system, parasympathetic stimulation is going to relax the bladder sphincter and contract the detrusor muscle, so you're going to urinate more. Your bladder becomes more leaky. In men, as we said, parasympathetic stimulation leads to an erection. So you have to have a balance of parasympathetic activity and sympathetic activity in order to have normal sexual function. Parasympathetic stimulation causes erection, and then just at the right time, you get a little sympathetic discharge that causes ejaculation. The mnemonic for this is point and shoot. So P stands for point and parasympathetic, and point is your erection. And then S stands for shoot. It also stands for sympathetic. So shoot is ejaculation. So just remember point and shoot, parasympathetic and sympathetic, erection and ejaculation. There's one more parasympathetic effect to talk about, and that's in the eye. In the eye, parasympathetic stimulation causes constriction of the pupil, or miosis. And the way I think about this is when you're resting, you don't need much light, you don't need to see much, so you can constrict the pupils because you just don't need to get that much light in there. So in the lecture on cholinergic agonists, we're going to see this mnemonic dumbbells, D-U-M-B-B-E-L-S-S, dumbbells. And this is going to help you remember what the effects of cholinergic agonists are. For the most part, this list is the same as the parasympathetic effects. Dumbbell stands for diarrhea, urination, meiosis, bronchospasm, bradycardia, excitation of skeletal muscle, lacrimation, sweating, and salivation. Now think about these for a minute. All of those are sort of excessive versions of the parasympathetic stimulation we've just been talking about. All but two of them. Which two of those that we just listed are not parasympathetic effects? Well, the first is excitation of skeletal muscle. This is a somatic thing, not an autonomic thing. But the somatic nerves, as we're going to see in a moment, are mediated by the same neurotransmitter as the parasympathetic system. And that neurotransmitter is acetylcholine. If you give a cholinergic drug, that is a drug that stimulates the acetylcholine receptors, you're going to stimulate those receptors in the visceral organs and get the parasympathetic effects, but you're also going to stimulate those receptors in the skeletal muscle, and you're going to get excitation of skeletal muscle. The other cholinergic effect on that list that's not a parasympathetic effect is sweating. Remember we said that when you see that cop with a radar gun pointed at you, you get sweaty palms, and that's a sympathetic effect. Well, it just so happens that even though most sympathetic transmission is by epinephrine and norepinephrine, the sympathetic innervation of the sweat glands is cholinergic. It's transmitted by acetylcholine. So if you give a cholinergic drug, you're going to stimulate those acetylcholine receptors in the sweat glands, and you're going to get sweating, which is a sympathetic response, not a parasympathetic response. So file that dumbbells mnemonic away. It's very high yield for your boards. It's very high yield for pharmacology. It's going to help you when we get to the cholinergic agonists and antagonists in the next couple of lectures. Let's talk for a moment about the role of the CNS, the central nervous system, in controlling the autonomic system. Your autonomic nervous system is going to react to changes in the periphery, so you have to have some sensory organs in the periphery. We talked about the carotid baroreceptors, and there are lots of other receptors that send afferent impulses to the central nervous system, to integrating centers in the central nervous system, such as the hypothalamus and the spinal cord. And this information is going to be processed, again, without any conscious control, without any voluntary control, and then that's going to modulate or regulate transmission of the autonomic nervous system. Emotional factors such as fear and anger and pleasure can also modify autonomic discharge and autonomic activity. We talked about when you see the cop with the radar gun, you instantly get this sympathetic discharge. That's based entirely on emotion and fear. You think you're going to get a ticket, so you have this fight or flight response. Now, most organs in the body receive what we call dual innervation. That means they get both parasympathetic and sympathetic innervation. You have to have this fine balance between the sympathetic tone and the parasympathetic tone for everything to work normally. Now, in any given organ system, one tone or the other is going to dominate. For instance, in the heart, the parasympathetic tone is the dominant tone. So heart rate is mostly modulated by the parasympathetic system through the vagus nerve. So you have an intrinsic pacemaker in your heart, which has got an intrinsic rate, which is a little faster than what you need. So the parasympathetic system through the vagus nerve is constantly applying a little vagus tone to the heart to slow that heart rate down just a little bit. If for some reason you need to raise the heart rate a little bit, well, the vagus nerve can just back off. You just have a little less parasympathetic stimulation, and the heart rate will naturally rise up. If you need to get your heart really going, though, you can give it a little sympathetic discharge to speed the heart rate up dramatically. To give you an automotive example, imagine you're cruising along at 70 miles an hour. Now you've got an accelerator and a brake pedal, but you don't put one foot on one and one foot on the other and work them both at the same time. You just work one or the other. And it's the same way with your autonomic nervous system. So you're cruising along at 70 miles an hour, and you just need a little bit of pressure on the accelerator all the time to maintain that speed. Now if you look down and you see that the speedometer is inched up a little bit and you're going a little faster than you wanted to, well, how do you slow down? Well, you just ease up on the accelerator and apply less of that tone, and your speed is going to decrease. You're going to kind of coast back down to 70 miles an hour. But if you see that cop with the radar gun and you want to stop suddenly, you're going to take your foot off the accelerator and hit the brake, and that's going to really slow you down quickly. So it's kind of the same thing as the parasympathetic and the sympathetic balance. So most organs have dual innervation, as I said, but a few organs only have sympathetic innervation. These are the adrenal medulla. As I mentioned, this is basically just a modified sympathetic ganglion. The kidney has only sympathetic innervation, and we mentioned that in the kidney, sympathetic innervation causes renin to be either increased or decreased. The pilomotor muscles, these are the muscles associated with the hair follicles that cause your hair to stand up on end. That's a sympathetic response. The sweat glands, as we mentioned, get sympathetic innervation. And blood pressure control is primarily regulated by the sympathetic system without much parasympathetic activation at all. Now let's talk about the neurotransmitters involved in the autonomic nervous system. All neurons communicate via chemicals that we call neurotransmitters. And the way this works is the presynaptic cell membrane is depolarized, and that generates an action potential that's carried along down the axon to the nerve terminal. And in the nerve terminal, there are voltage-gated calcium channels that open up when that cell membrane is depolarized, and that allows calcium to flow from outside the cell to inside the cell. And that calcium in the cell triggers exocytosis of neurotransmitters that have been packaged in vesicles. So whatever neurotransmitter that cell is producing is going to be packaged and ready to go, and when the action potential gets there, opens up the calcium channel, those neurotransmitters are going to be secreted. That neurotransmitter then diffuses across the synaptic cleft, and it binds to a membrane receptor on the postsynaptic nerve. So there are a lot of different neurotransmitters out there. There are more than 50, but there are really just 7 that are really important in the nervous system. The really important ones are norepinephrine and epinephrine, acetylcholine, dopamine, serotonin, histamine, and GABA, or gamma-aminobutyric acid. Each transmitter is going to bind to a specific family of receptors. The big neurotransmitters in the autonomic nervous system are acetylcholine and norepinephrine and epinephrine. And in subsequent lectures, we're going to talk about the synthesis of these transmitters, the reuptake and the degradation of these transmitters. These are important topics, but there's just not room for them in this lecture. So let's talk first about acetylcholine. So a little terminology. When we talk about a nerve that produces acetylcholine, we call that nerve cholinergic. When we talk about a receptor to acetylcholine, we call that a cholinergic receptor. So you see from this diagram that acetylcholine is the transmitter in all of the ganglionic synapses. Whether it's parasympathetic or sympathetic, all the ganglionic synapses are cholinergic. You'll also notice that all parasympathetic synapses are cholinergic. So the synapse of the postganglionic neuron with the effector organ is also cholinergic. Acetylcholine is also the transmitter involved in the somatic nerves, the motor nerves, and you'll notice here that there are no ganglia involved. You can also see that there are 2 types of acetylcholine receptors. There are muscarinic receptors and nicotinic receptors. Acetylcholine is the same molecule, but the receptors and their effects are different. And you'll notice the distribution. The somatic motor nerves are acting on nicotinic receptors. The preganglionic sympathetics are acting on nicotinic receptors. The preganglionic parasympathetics are acting on nicotinic receptors. So one way to think about it is that all peripheral fibers that originate in the CNS, whether it's autonomic or somatic, are producing acetylcholine and affecting a nicotinic receptor. The postganglionic parasympathetics are acting on muscarinic receptors. This is the only muscarinic receptor in the entire chart. There are other cholinergic neurons and nicotinic and muscarinic receptors elsewhere in the central nervous system. Next, let's talk about norepinephrine and epinephrine. So again, the terminology, the nerves that produce norepinephrine and epinephrine are called adrenergic, and the receptors are called adrenergic receptors. So everybody's heard of adrenaline. We talk about the adrenal gland, and we talk about adrenergic neurons, but then the transmitters are called epinephrine, norepinephrine. It's kind of confusing. The situation is that adrenal comes from Latin. Ad means near, and renal means kidney. We talk about the renal artery or the renal vein, so that's kidney. So the adrenal gland is the gland that's near the kidneys. epinephrine comes from Greek. Epi means over or upon. Nephros is the Greek word for kidney. We talk about the nephron as part of a kidney. So epinephrine means the gland that's over the kidney. We could have talked about the epinephric gland, but for whatever reason we talk about the adrenal glands producing epinephrine, and then the similar chemical is norepinephrine. So you can see that all postganglionic sympathetic transmission is adrenergic. The postganglionic sympathetics secrete norepinephrine and act on adrenergic receptors. The adrenal gland releases epinephrine in response to preganglionic stimulation. And remember that the adrenal medulla is basically just a big sympathetic ganglion. So we already discussed one organ that receives sympathetic innervation that is not adrenergic. You remember what it was? It was sweat glands. And you remember what kind of transmission the sweat glands used? They receive cholinergic transmission. They're stimulated by acetylcholine. So if you had to guess, would you guess that those acetylcholine receptors on the sweat glands were muscarinic or nicotinic? Well, just like the postganglionic parasympathetic nerves act on muscarinic receptors, so the postganglionic sympathetic nerves in the sweat glands act on muscarinic receptors. Now there's one last topic we need to cover, and it's a really complicated one, but it's also very, very high yield. We're going to talk about how these receptors work. Well, they work through something we call second messengers. So a neurotransmitter doesn't really do anything to the cell it's attaching to. It just transmits the signal from one neuron to the next. It's the receptor that's responsible for triggering a response in the downstream cell. So there are a couple of different ways that this happens, and one is through ion channels. Some receptors are linked to ion channels that regulate ion flow across the cell membrane. When the transmitter binds to the receptor, it opens the channel or closes the channel. These receptors have a very rapid response. It may only last a few milliseconds or even less. One example of this is the nicotinic acetylcholine receptor. It's an ion channel. Acetylcholine binds to the receptor and opens up the channel and allows sodium to enter and potassium to leave, and that causes depolarization of the cell and generates an action potential. The other big category of receptors used in the autonomic nervous system are G-protein coupled receptors. The G-protein receptor molecule is a single peptide with 7 transmembrane proteins that are represented like a bundle of sticks, or I often think they're represented like a bundle of dynamite. And then you have a G protein, which is linked to the receptor. There are 3 subunits of this G protein. You have the alpha subunit, the beta subunit, and the gamma subunit. The alpha subunit has an intracellular component, and it can bind to GTP, which is guanosine triphosphate, or it can bind to GDP, guanosine diphosphate. So the way this works, the transmitter binds to the receptor, and that causes a conformational change in this receptor molecule. That conformational change activates the alpha subunit so that the GTP can bind to it, and when GTP binds to the alpha subunit, this G protein undergoes a conformational change. The beta-gamma subunit dissociates from the alpha subunit. The beta-gamma subunit can go on and affect some other enzymes. The alpha subunit can go on and affect other enzymes. The signal is then perpetuated downstream by what we call second messengers, which is whatever the enzyme products of this enzyme are. Eventually the G protein will self-hydrolyze the GTP back to GDP, which will reset the G protein. In the autonomic nervous system, muscarinic receptors and adrenergic receptors are both linked to G proteins. Now there are a lot of different enzymes that G proteins can either activate or inactivate to go on to produce these second messengers. The 2 in the autonomic system are phospholipase C and adenylyl cyclase. Now before you completely zone out, I want to remind you that this stuff is very high yield. It's also totally clinically irrelevant. This is really nitpicky details. You're not ever going to need this in practice, but it's very high yield for your board exams. It's very high yield for pharmacology exams. So you're just going to have to memorize this for your exams. We're going to talk about 13 different receptors that are linked to G proteins. We're just going to mention them briefly here. The adrenergic receptors are alpha 1, alpha 2, beta 1, and beta 2. The muscarinic receptors are M1, M2, and M3. Dopamine receptors are D1 and D2. Histamine receptors are H1 and H2. And vasopressin receptors are V1 and V2. Now obviously Not all of these are involved in the autonomic nervous system, but you'll want to know about all of these for the boards. Again, the action of the different adrenergic receptors are going to be covered in the lectures on the adrenergic systems, and that's very, very clinically relevant stuff, so you're going to want to pay attention in those lectures. So let's go back to phospholipase C and adenylyl cyclase. So G proteins can activate phospholipase C, which leads to an increase in inositol triphosphate and diacylglycerol. Inositol triphosphate increases intracellular calcium, which leads to secretion of various cell products, and diacylglycerol regulates protein kinase C. So remember, phospholipase C leads to regulation of protein kinase C. So remember the C. G proteins can also activate or inhibit adenylyl cyclase, which is responsible for turning ATP into cyclic AMP. And then cyclic AMP stimulates protein kinase A. So if you think about A for adenylyl cyclase and A for ATP and cyclic AMP, you remember that that is going to activate protein kinase A. So there are three classes of G proteins that are important to talk about: GQ, GS, and GI. GQ is the class of G protein that activates phospholipase C. You can think of the word cutesy. GQ activates phospholipase C, whose products increase protein kinase C and calcium, C for calcium, so cutesy. The receptors linked to GQ proteins are H1, alpha-1, V1, M1, and M3. So there's a mnemonic, have 1 M and M, which stands for H1, alpha-1, V1, and M1 and M3. And you can remember that cutesies, little kids, have 1 M and M. GI is the class of G protein that inhibits adenylyl cyclase, and that's going to reduce cyclic AMP and therefore reduce protein kinase A. So GI, the I stands for inhibit. The receptors linked to GI proteins are M2, alpha-2, and D2. And the mnemonic is MAD2s. M for M2, A for alpha-2, and D for D2. GS is the class of G protein that stimulates adenylyl cyclase, and that's going to cause an increase in cyclic AMP and then an increase in protein kinase A. So GS, the S is for stimulate. The receptors linked to GS proteins are basically all the rest that we haven't covered so far: beta-1, beta-2, D1, H2, and V2. There's no real mnemonic for this. It's just, you just remember that all the other receptors not covered by have 1 M and M and MAD2s are linked to GS proteins. So again, these classes of G proteins are not really important clinically. They're no fun to memorize. You can't really reason them out or understand them. You just have to memorize them. But they're very high yield and they frequently show up on your exams.
Okay, now let's pause for a moment and review the material that was just covered. Before we do that, if you haven't already done so, this might be a good time for you to read your pharmacology text that corresponds to the material that was just discussed. Then together, we're going to go through the quick review in your study guide.
So, we meet again, 00.
You'll never get away with this gold.
Oh, really? Well, I think my new pets may beg to differ.
You are a sick, twisted man.
It doesn't have to come to that, 00. All you have to do is answer me one simple question.
Never. You'll never get information out of me.
Never say never, 00. Prepare the bunnies!
No, okay. I'll tell you anything you want. Just have mercy, please.
How does autonomic stimulation affect the normal male sexual function?
There's nothing about my sexual function that's normal.
Release the bunnies!
Okay, I'll tell you. Parasympathetic stimulation causes erection, and sympathetic stimulation causes ejaculation.
Oh, no!
How could you not know that? It's as easy as point and shoot.
All right, let's go through the answers to quick review number 2. Number 1, what is the second messenger pathway that mediates epinephrine stimulation of alpha-1 receptors? Very important pathway to know, very high yield for board exams. So epinephrine is going to bind an alpha-1 receptor. And what was the G protein that's associated with alpha-1 receptors? GQ. So epinephrine binds to alpha-1. Alpha-1 stimulates GQ receptors. What does GQ do? Remember the mnemonic was cutesy. GQ stimulates phospholipase C. What does phospholipase C do next? It cleaves phosphatidylinositol bisphosphate into inositol triphosphate and diacylglycerol. Let me say that again. Phospholipase C cleaves a phospholipid called phosphatidylinositol bisphosphate, commonly abbreviated as PIP2, and it cleaves that molecule into inositol triphosphate and diacylglycerol. Again, very important for board exams to know that. What do each of those molecules do? Inositol triphosphate increases intracellular calcium, and this has numerous downstream effects. But what does increasing intracellular calcium do on smooth muscle? It stimulates smooth muscle to contract, right? So you're going to have vasoconstriction as a result, and this is why alpha-1 receptors cause vasoconstriction by way of this pathway. And then you have diacylglycerol is the other molecule. It regulates protein kinase C, and this causes, what does a protein kinase do? A kinase causes phosphorylation, so diacylglycerol stimulates protein kinase C to phosphorylate things, and this also has numerous downstream effects. Number 2, what mnemonic other than dumbbells is commonly used to remember the effects of excess parasympathetic stimulation? So dumbbells is a great mnemonic. I want to throw this other one out there because you might encounter it. I don't want it to confuse you. It just reiterates a lot of the dumbbells information. The mnemonic is sludge, S-L-U-D-G-E. The S is for salivation, L is for lacrimation, U is for urination, D is for defecation, G is for GI upset, which includes diarrhea, and E is for emesis. Again, you just get leaky everywhere. So if you know leakiness associated with parasympathetics, you don't need to really know either of these mnemonics, but they can be helpful. Now, just to clarify, mnemonics can be tricky, and they're seldom is it the case that mnemonics are 100% informative. And so let me just discuss a couple ins and outs of these two mnemonics. So the sludge mnemonic, of course, doesn't have the meiosis component in there, so sometimes you might see sludge-M as a mnemonic, so just to throw the meiosis. I don't think that's very helpful, though, because midriasis also starts with an M. So just something to be aware of. Now, the other thing to note about this mnemonic, it is the sludge mnemonic is technically more accurate of parasympathetic stimulation than is dumbbells. And this was mentioned earlier in the lecture because the dumbbells mnemonic has excess sweating, and it also has muscle excitation as a part of the mnemonic. And we mentioned that those are not necessarily parasympathetic stimulation resulting, but rather cholinergic agonist excess. So, to be technically correct, you could say that excess parasympathetic stimulation is the sludge mnemonic plus meiosis, and excess cholinergic agonists in the system by way of poisoning with a cholinergic agonist, such as organophosphate poisoning, results in your dumbbells mnemonic. Okay, one other thing to mention about the sludge mnemonic that I don't really like about it is that it implies that something is very slow moving, which is kind of counterintuitive when you're trying to suggest leakiness. So sludge mnemonic is kind of counterintuitive. Number 3, what are the autonomic components of the male sexual response? So we talk about the male sexual response so much because it is an interesting interplay between sympathetic and parasympathetic. And so this is your point and shoot mnemonic, of course. So parasympathetic is your point, it's erection. I think it's worth knowing that this is mediated by your pelvic nerve. And there's actually 3 components to the male sexual response, if you want to be technically correct. The second component is emission, and then the third component is ejaculation. So what is emission? Emission is the sperm traveling from the epididymis to the prostatic urethra. And this is, again, sympathetically mediated. So this is your shoot mnemonic. And this is by way of the hypogastric nerve. And then the third component, ejaculation, is by a third nerve, which is your pudendal nerve. And this is where the sperm and prostatic fluid are exiting out of the penis. And this has both a somatic and sympathetic component to it. Number 4, What is the nerve root origin of the pelvic nerve responsible for erection? So we talked about the cranial nerves that have a parasympathetic component. There's also your sacral plexus that has a parasympathetic component. And so the mnemonic here is S2, S3, S4, keeps the penis off the floor because it causes, these are the nerve roots that are responsible for erection by way of the pelvic nerve. What were the parasympathetic nerves that were your cranial nerves? They were cranial nerve 3, cranial nerve 7, cranial nerve 9, and cranial nerve 10. So make sure you know those. Number 5, what is the other name for vasopressin? Now, we didn't talk much about vasopressin in this lecture. We did mention V1 and V2 receptors and the G proteins associated with them. This is just something to be aware of. Vasopressin is also known as antidiuretic hormone. Same thing, different words used to describe the same thing, which, antidiuretic hormone is commonly abbreviated ADH. Number 6, many insecticides are a type of organophosphates that are potent stimulators of the parasympathetic nervous system. And a farmer or gardener with organophosphate poisoning, what would be the expected appearance of the pupils? With excess parasympathetic activity, you're going to have meiosis, right? So you're going to have constricted pupils, and so that's something to be aware of with organophosphate poisoning or insecticide poisoning, excess parasympathetic drugs on board. All right, let's move on. Number 7, which neurotransmitter is released in the sinoatrial node of the heart in response to an increase in blood pressure as detected by the carotid sinus? This is acetylcholine by way of the vagus nerve. Okay, so now's a good time to pause the video and complete your in-session quiz, then restart the video and we'll go through the quiz together.
Hi, I'm Dr. Chris Lewis. I'm one of the chief educators here at Doctors in Training. Today we're going over the in-session quiz on the lecture of the autonomic nervous system. Let's get going. Which division of the autonomic nervous system functions as a unit, discharging as a complete system? Well, that would be sympathetic. How do the sympathetic and parasympathetic systems affect the following target organs? So there's a bunch of them here. First, let's start with the heart. So on the sympathetic side, you're going to get an increase in heart rate and an increase in contractility. On the parasympathetic side, you're going to get reduced heart rate and reduced contractility. With the trachea and the bronchioles, you're going to get dilation with sympathetic tone. You're going to get constriction and increased secretions on the parasympathetic side of things. Blood vessels, and we'll divide this up into skeletal muscle and skin and GI. So on the skeletal muscle, blood vessels, on the sympathetic side, you'll get dilation. Parasympathetic, you're not going to get anything at all. You're going to get no response. On the blood vessels of the skin and the gastrointestinal tract, you're going to get contraction and constriction on the sympathetic side and no reaction on parasympathetic side. Gastrointestinal. So you're going to get decreased motility and decreased muscle tone and contraction of the sphincters with a sympathetic stimulation. And on the parasympathetic side, you're going to get increased muscle motility and tone. Next, on the ureters and bladder, for the sympathetic side, you're going to get relaxation, both of the detrusor muscle, and you're going to get contraction of the sphincter. Now for the parasympathetic side, you're going to get relaxation of the bladder sphincter and the trigon, and you're going to get contraction of the detrusor muscles. Genitalia, we'll divide this up into female and male. So first female, on the sympathetic side, you'll get relaxation of the uterus. On the parasympathetic side, you'll get no reaction. On the male side of the genitalia, you'll get sympathetic stimulation will cause ejaculation, and parasympathetic will stimulate erection. Remember from the Dr. McGinnis's lecture, point and shoot. So point and shoot. So parasympathetic is pointing, sympathetic is shooting. So that goes along with erection and then ejaculation. Next, we'll move on to kidneys. So sympathetic stimulation will lead to an increased secretion of renin. Parasympathetic side, no reaction. Next, let's move on to the eyes. Sympathetic stimulation will result in dilation of the pupils, or mydriasis, and this is through contraction of the iris radial muscles. On the parasympathetic side, you'll get constriction of the pupil, or meiosis, and this is contraction of the ciliary muscles. Next, salivary glands. sympathetic stimulation, thick, viscous secretions. Parasympathetic side, copious, watery secretions. Sweat glands, sympathetic, you'll get increased sweating. Parasympathetic, nothing. Lacrimal glands, sympathetic side, nothing. Parasympathetic side, you get increased tear production. And we'll talk. The next question will remind us that parasympathetic side makes things leaky. Adrenal glands, sympathetic side, you'll get epinephrine and norepinephrine secretion and release. Parasympathetic side, nothing. So in general, what effect does parasympathetic stimulation have on secretory tissues? So this includes lacrimal glands and salivary glands. Well, we just mentioned this just a second ago. It'll be an increase of secretion, so it makes them leaky. Which cranial nerve is the primary parasympathetic nerve for all organs in the thorax and abdomen? Well, this is the vagus nerve. And which cranial nerve number does that associate with? Number 10. So vagus nerve, cranial nerve 10. Next question. Complete the table regarding classes of G proteins. So first one is GQ, or the handsome protein. And what are the receptors involved? Well, that would be H1, alpha 1, V1, M1, and M3. And remember the mnemonic for this. This is have one M and M. Now the enzyme affected is phospholipase C. And the enzyme products, or the second messengers, are diacylglycerol, and this will activate protein kinase C, and then you'll get inositol triphosphate, and this will regulate intracellular calcium. Next is GI, and the receptors involved are M2, alpha 2, and D2. Remember, this is the MAD2s. And the enzyme affected is that it inhibits adenylyl cyclase. So this will result in the second messengers as a decreased cyclic AMP. And this will subsequently decrease activation of protein kinase A. And now we have the GSG protein. And this doesn't fall into any mnemonic. You just have to remember that it doesn't fall in, it's the ones left over after the other two mnemonics. And you get beta 1, beta 2, D1, H2, and V2. And it stimulates adenylyl cyclase. And the enzyme products are an increase in cyclic AMP, and this activates protein kinase A. Next, so fill in the blanks of the graphic of the pre-ganglionic and post-ganglionic transmitters and receptors. So look at the picture here. In the top left corner, we're starting with sympathetic innervation of adrenal medulla. And then it's going to stimulate with acetylcholine at the ganglionic synapse. And then at that synapse where it's going to release epinephrine, and that epinephrine is going to interact with an adrenergic receptor. So moving back up at the top, moving one nerve over, you have sympathetic activation, and it's going to use, again, acetylcholine. Remember, all of the ganglionic synapses are going to use acetylcholine. And then it's going to release norepinephrine, and that's going to stimulate an adrenergic receptor. Moving one more over again, we got parasympathetic activation, and it's going to use, again, what? Acetylcholine, like all the other ones. And then it's going to release, again, acetylcholine, and it's going to affect a muscarinic receptor. And then finally, on the far right side, we have a somatic nerve, and it's going to it's not going to have a ganglionic synapse, and it's going to release acetylcholine, and it's going to directly act on a nicotinic receptor. Next question. What receptor is used in somatic motor neurotransmission? Well, the answer to that is a nicotinic acetylcholine receptor. Next, what G protein class do the following autonomic receptors stimulate? Well, we went through a similar question. So alpha 1 is a GQ. Alpha 2 is a GI, beta 1 is a GS, beta 2 is a GS, M1 is a GQ, M2 is a GI, and M3 is a GQ. Next, list the neurotransmitter secreted by each neuron. So first is preganglionic sympathetic, and it's going to do acetylcholine. Next, somatic motor nerve. That's going to use only acetylcholine as well. Postganglionic sympathetic. This is going to be norepinephrine, and it's going to go after that adrenergic receptor. Postganglionic parasympathetic. So this is going to be acetylcholine. And finally, which two effects of cholinergic drugs are not mediated by the parasympathetic nervous system? That's going to be excitation of skeletal muscle and sweating. That concludes our in-session quiz for the autonomic nervous system.